Welcome back to Rhythm Interventions Online. I'm Devi Nair. This session is titled The Importance of Trigger Mapping in AF and VT. For this session, we have two short case presentations and time for discussion, so please stay involved by submitting your questions. The cases will be presented by two of my dearest friends, Dr. Anish Amin from Columbus, Ohio, and Dr. Benjamin D'Souza from Philadelphia. We're also delighted to have Dr. Atul Verma from Montreal, Canada, join us as a panelist. Welcome to all of you. We have a lot to get through. In a relatively short session. So before we kind of get into the slide decks with you, I just want to take a minute and talk to you about where do you see the role of mapping in the current era of pulse field ablation, and whether it's in AF or hopefully PFA and VT. Do you feel like the field is moving away from mapping, and is AF mapping and VT mapping, does it need to come back? I'll ask Atul. You're the wisest of among all of us, right?
Well, I don't know about that, Devi, but I certainly have very strong opinions on this. You know this. Look, pulse field ablation is just an energy. It's an energy that comes out of a catheter. It's not magic. It's not a potion. It's not, gene therapy. It's just an energy that comes out of a catheter. It's different than thermal energy, and that's about it. So the notion that we don't need mapping anymore is, I think, throwing out the entire field of electrophysiology. We absolutely need mapping for AF, for VT, for everything. And just because we changed what's coming out of the catheter doesn't mean it's magic.
You know, on that note, I think I'm going to hand it over to Anish, who's going to take us through his case where he actually maps AF.
Well, thank you again, and pleasure to be here to share a couple of our cases and our experience with an AI-enabled ECG solution for arrhythmia mapping. I couldn't agree more with Dr. Verma with the commentary around the need for developing smarter mapping as our technologies for therapy become more and more efficient. We need to recognize what exactly are we going to ablate and why, and regardless of the way we choose to complete that, contact mapping or ECG solutions like the one Ben and I are going to talk about today, it is critical to keep us engaged in our field of EP. So what is this? Vector mapping is called VMAP for shorthand, is an AI-enabled ECG solution. In essence, taking portions of the ECG of interest and looking back in time to computer models of the same arrhythmia, trying to identify patterns that patterns of interest and patterns that help localize where the arrhythmogenic focus is. So the way this is completed is initially pre-specifying what arrhythmia you're interested in, and subsequently identifying the PVC, the VT, the fibrillatory pattern on the ECG that you're loading into the system. So very briefly, I'll show you that the setup is quite simple. The initiation screen essentially begins with starting a new case on what looks like a laptop that can be set up inside of the EP lab. Acquisition is completed through the recording system. Some basic elements for the patient data are entered, and the ECG is in essence uploaded onto the software. Once this portion is completed, in a matter of a handful of minutes, the system will identify automatically areas of interest, and then allow the user to manually manipulate those as well. So what that looks like is something like this. in this case, we're looking at atrial fibrillation. You can see the fibrillatory waveform is annotated in blue. The resultant map that's produced is a biatrial map. In this case, something that's called a beat summary average. So taking multiple different fibrillatory portions of the ECG, averaging them together, highlighting those that have consistent activation as an average, in this case, along the anterior portion of the RA and down towards the CTI line. Similarly, that data can be presented in what is called a beat average composite. What that actually looks like is taking each one of those data points and then placing them, overlaying them on top of each other, so that what you get is actually more or less a heat map showing areas of interest. So the case that I'm showing you right now is a patient of mine who's in his early 70s. He had persistent type atrial fibrillation and underwent a prior hybrid ablation in 2017. He was off antiarrhythmic drug therapy for many years, ultimately went back on a Class C antiarrhythmic in 2020, and then represented with a HFpEF admission, and then had serial encounters with us for recurrent atrial fibrillation. So we arrived for a redo ablation. I thought, what a great opportunity to use a solution like this to help us understand areas that may be of interest. So we put this together along with a persistent mapping algorithm from Boston Scientific. If you recall, what you just saw on the vector composite summary was that the posterior wall demonstrated no triggers of atrial fibrillation according to that analysis, despite, as you can see here, continued conduction in the LI-PV and in the RS-PV. So the importance of this, of course, from my lens, is that we need to look outside the PVs, and I think we're all very aware that many patients have non-durable PVI and do quite well. And defining a strategy for them at redo can be quite complex. So in this case, we created a biatrial map. We show that we have continued conduction in the veins. We know we have to go at least start with a pulmonary vein isolation, which we did, following which we did another vector map, again, demonstrating that the posterior wall and the pulmonary veins demonstrate no significant areas of interest, but certainly areas of interest along the septum, continued areas of interest in the right atrium and the lateral wall of the left atrium. This is what that composite map looks like. Again, these are each one of those areas of interest off the ECG overlaid upon each other. So again, lateral wall of the left atrium, the floor going up into the septum, and then the lateral, right? So as Dr. Verma mentioned, when we're using a tool which essentially turns ablation into a little bit of a game of horseshoes and hand grenades, we can fairly efficiently go through ablation of the area just underneath the left inferior vein. We also applied ablation along the floor, and then finally turned our attention over to the right atrium based upon a repeat map. Again, the beat summary is demonstrated here. Now we can see that most of the areas of interest are in the right atrium. And if we look at that composite summary, there's a composite map, we see areas of interest in the SVC. So we did complete an SVC isolation and ultimately at that point completed a CTI line, which was non-durable from our previous ablation, and then cardioverted the patient. So when I walk away from, I'm sure many viewers would say, gosh, we pretty much just took a diffuse ablation approach to this. And in some respects, that's true. But the key learning for me was that we didn't just take a patient with rather complex arrhythmia substrate and simply go remedy the non-durable lesions from his prior ablation. We looked for additional learnings and then tried to target some of those areas without necessarily indiscriminately ablating, for instance, left atrial appendage or the entirety of the floor, et cetera. So for our practice, this has been something that has been keenly evaluated and certainly welcomed in some of these more complex cases.
Thank you for a great presentation, Anish. I want to take the first question and direct it to you, actually. Do you see these patterns being reproducible? Say if you do it, if you do it, say, an hour apart, are these patterns the same? Have you looked at whether if you've mapped them a month later, do they look the same? Does it matter if I ablate them on a Monday or a Friday?
Well, I think you bring up a really, really interesting question. So right now we're only completing the ECG analysis in the lab when the patient's already on the table in preparation for the procedure. But I do see that a unique role for this would be to serially examine a patient in an outpatient setting. And just as you said, if the areas of interest remain stable, we can certainly counsel patients about a directed therapy prior to them actually being in the lab. And that is the true power of using something or using a algorithm that's based on something as simple as an EKG.
Atul, what are your thoughts about how this is going to impact like this current standard of care? Like, how would you use this?
Yeah, I guess, Anish, I have a bit of a question about what exactly we're mapping here, because you're mapping fibrillatory waves on the ECG. Usually, if we're trying to identify, let's say, a driver, we look at unipolar electrograms. If we're looking at certain patterns of activation, which could be suggestive of rotation, you can look at bipolar electrograms. Triggers, we map, when we're not in AFib. So if you think about triggers, drivers, and other sort of electrogram patterns, what do you think we're mapping here with the fibrillatory waves on the ECG?
Yeah, I think you're absolutely right. Like when we convert the analysis from a intracardiac analysis to something that's a surface ECG, now all of a sudden we are embedding a lot of trust in the deep learnings of the ECG as it relates to things that the system has seen. Because remember, this is not novel understanding that's being drawn out of the ECG in the moment. It's a look back at what the system has been trained to do based on computational models of arrhythmia and unique substrates. So you're absolutely right that if we haven't trained the model well, then what we get out is going to be deficient in many ways. And I do think that it is a leap of faith to go from everything that we know or that we're learning about AF mechanisms to, straightforward to use, simplifying it down to an ECG and trying to leverage an algorithm to understand it for us. I think it's really more to build the conversation around what can be done and how we should be thinking about, the types of the ease and the simplicity of some solutions. It's not going to be for everyone, right?
All right, yeah, I will actually hand it over to Benjamin now, who will share his case. Ben.
All right, sounds good. Thanks, Debbie. And thank you to everybody for having me and some very interesting conversations. Obviously, we talked about the atrium. Now we're going to talk about the ventricle, and then we'll sort of put it all together. Now, I would say that for ventricular arrhythmias, that this concept of AI, ability to predict areas of targeting would likely be even easier and more straightforward with a 12-lead EKG, like has been hammered into my head for years of training at Penn as to where ventricular arrhythmias are coming from. So I'm going to present a case and then happy to answer any questions. But this was a 65-year-old gentleman who was admitted at Penn who had basically in VT storm, multiple shocks for pretty much what looked like the same fast monomorphic ventricular arrhythmias. He's an ischemic, EF low, 10 to 15. Had actually recently taken a drop after his double valve surgery of mitral and tricuspid surgery. And he's a sick gentleman to the point where he needed Impella support perioperatively and postoperatively for some time. So we kind of knew going in that he was not a healthy patient, which pretty much all of our patients with VT storm are. And so my approach with these cases, essentially is variable. The traditional way that I learned and that we did VT ablation at Penn was that we would try to activation and entrain map the VT. The problem with someone with this, sick of a heart, is that they're not going to tolerate it. So, we would traditionally have put this patient on ECMO to be able to do that. But instead, I tried to use some sort of non-invasive surrogates. So we brought the patient in, we had them under MAC conscious sedation and then induced VT. So this is the VT that was induced, as you can see here. Left bundle is purely directed, positive in 1. And the patient tanked immediately. So you could see the A line just went right into the toilet, and we had to shock the patient right away just to get them out of this and stabilize them, made sure that everything was okay with easily induced with doubles that was able to induce this. Again, I went transeptal. So you can see here that LA mean for this patient was 40 starting the case. So he was floridly in heart failure when we started, and obviously a sick gentleman that I'm not really thrilled about keeping in a ventricular arrhythmia. So we inputted this into VMAP, and this was sort of the predicted area on the interventricular septum. And interestingly, pre-procedurally, he had a cardiac MRI, which we do try to do for many of our patients. Thankfully, we can image pretty much anyone with any device at Penn to be able to help us localize scar. And the scar, as you can see here, sort of matched the location per se where I thought this ventricular arrhythmia is coming from, and the 12 lead kind of fits with that too. So did this map via transeptal. Let me make sure this plays. Sorry, guys, trying to see if this will play for me. There we go. So again, via transeptal approach, I think there's been some pretty decent published articles showing that transeptal versus retrograde approach is likely safer, especially in someone who has atherosclerosis and plaque, and we don't want to break off that plaque. Crossed their aorta multiple times. In this case, the patient had mitral valve surgery relatively recently. It was a prosthetic valve, so I wasn't too worried, but I'm a little worried about causing harm there. So you could argue retrograde might be a better approach in this case. But regardless, did the map with HD grid, which you can see here. Because I had multiple modalities, both imaging and our VMAP sort of telling me, hey, Ben, pay more attention to that area of the interventricular septum. I did a full map regardless. This was done in sinus. The rest of the case was done in sinus so that I could, and just to be clear, I did intubate him after this so that we could have a sort of more stable platform to be able to do his mapping and subsequent ablation. So started with max/conscious sedation, then had a target to be able to go to with a 12 lead, and then got him out of it, and then went to ablating. So again, I think there's been multiple, I saw Rod was presenting earlier, interest in looking at mapping, right? We mentioned at the beginning of this talk that mapping is important. And I think that I've been very disappointed at the way our field has gone to go away from mapping and more anatomic, less thought related to ablation. And I still think that, as mentioned, pulse field ablation is super exciting in terms of a modality, but it's an energy modality. It's our job to figure out where we are supposed to deliver that energy regardless of the type. So traditionally, if someone was not want to keep a patient in VT, we would do substrate modification, which I've said before to some people's chagrin is that it's not a very elegant way to do a VT ablation, but it works for many. The problem is you have to do it for a long period of time. You can see here is bipolar voltage map showing pretty significant scar throughout almost all of the interventricular septum. But then if you use, ILAM in this case to look at these areas of isochronal crowding, it kind of suggests an area that's not necessarily the entire septum. And interestingly, that's the same area that VMAP predicted as Anish had alluded to earlier, a hotspot as they refer it to, an area of interest. We did pacing, so pace mapping to be able to look, the traditional way that we would try to without keeping the patient in VT, find the area of interest. And you can use VMAP, as was alluded to earlier. It uses the 12-lead ECG, so it's very simple. You can map as many times as you want. It takes 30 seconds, and then you can just do it again and again and again. So you can do that in a case, either atrial or ventricular at any time. If you have a single beat, PVC, PAC, you can map that. We talked about atrial fibrillation. You can actually map primary ventricular fibrillation, which I'm very interested in doing, and not PVC triggered VF, primary VF. So all these I think are pretty interesting to me. Again, all trying to do this case without this patient dying on me or having to crash on ECMO on my table. And so here are the sort of vectors using ILAM and, just again, different ways looking at directionality, whether you're using HD grid or using an Octaray or whatever catheter you prefer to look at those areas, but all kind of pointing me towards that same location, sort of lower on the septum. Then we looked at, again, additional ways. I think that all of the mapping companies are really developing even more sophisticated ways for us to look at electrograms beyond our eyes. And this is just showing those areas of slow conduction with peak frequency, looking at the near field, and you can see the map here. Again, sort of showing the same location again. And then this is just still images in the interest of time, showing these really, in my opinion, beautiful looking signals of fractionation and late potentials and areas of interest. Again, all pretty much correlating with the area that VMAP predicted would be a potential area of interest, so to speak. And then you overlay that on an ILAM and looking at the areas of high frequency as well, and you can see the electrogram signals there as well, all particular areas of interest. So moving on, again, just showing another area a little bit higher up and more anterior in the same potential areas of targeting for ablation, whether it be, in that anterior area of scar. So move forward with an ablation strategy, utilizing a combination of the non-invasive mapping, the MRI, the VMAP, as well as the contact mapping that showed our areas of ILAM, as well as near field, high areas of fractionation. So again, ablation here, 40 watts with Tactiflex. I really like this catheter in terms of ablation. Again, this is just one example of it, whether you use this or QDOT, or, in the future, as we start fooling around with PFA in the ventricle as well, which I think some believe may be our future. But, beyond just destroying the ventricle and a patient has an EF of 10 for that entire scar, which would have taken a long time. I made a little bit, sorry, I skipped forward. This is just ablation in that very specific area that I first targeted, that was pointed to me with VMAP. And then, so lesion set at the end. So this is overlaying all of it together, right? So you have the VMAP, you have your ILAM area of, latent activation, you have scar, and put it all together, and your MRI too. It all kind of correlates to the same space, which is nice. And it did somewhat more of a targeted ablation than I would traditionally do if I was doing a substrate modification. So I really only targeted these areas that you can see here. And then re-induced. So re-induced the patient. And if I did induce VT again, I could have mapped it again with the same technique, shocked him out of it right before, anything bad happened. I would only need a couple beats of it. I don't need it to sustain to do activation mapping, and then go from there. In this case, he was non-inducible with multiple areas from the LV and RV. I woke the patient up so that it wasn't just related to the general anesthesia, did it again, and really had nothing. This case was like probably 6 months ago or so, and he hasn't had anything since. He's off amiodarone. He's doing well. And so thankfully he did not decompensate and, potentially die on the table. He was certainly sick enough to do that. It allowed me to non-invasively map, but with somewhat more confidence than just doing a substrate modification without inducibility. Inducibility at the beginning of the case, non-inducible at the end of the case is obviously my goal for many of these patients. And I am excited for the possibility of these sort of AI mapping tools to help us localize whatever arrhythmia we're targeting, with greater efficacy and really speed, right? This case was less than an hour and a half stick to protamine, which I think is pretty good for a VT storm case in terms of, getting this gentleman off my table without anything bad happening to him. So I'll stop there and answer any and all questions.
Thank you, Ben, for that great case as well. And, that very personalized approach that you were able to provide for this patient. And, just from your experience, and both Anish and both of you come on in on this one, how accurate are these maps when you're looking for, say, PVCs and VTs? And the reason why I'm asking is I think many operators don't take patients in with VT for procedures because of the concern of, is it something I can do? Or, and so do you think a more personalized approach like this is going to open the or take away the bottleneck that these patients have? Because I do think that patients don't get the care they need sometimes.
Yeah, that's a good point, Devi. And so what I would say is the maps are fairly accurate now. We're not talking within a millimeter because currently, the VMAP doesn't integrate into either a mapping system or overlay onto a CAT scan. So you really don't have pinpoint, but you do have, relatively helpful ways to tell you where this is coming from. So for instance, if this was a patient that I was not comfortable doing epicardial ablation in, and he's an ischemic, there's a good chance he may have a target there. You could certainly use this to guide, whether you thought you were comfortable doing the procedure or not. So I think, as Anish's point is, you can do this from anywhere. You essentially, you could do a NIPS in the hospital and induce VT and map it and decide if that's something you wanted to move forward before putting on the table and under anesthesia, or you could do it during the case. You could utilize it pretty much how you want to. If you have that PVC patient who comes in that, you guys know, you give a little bit of fentanyl and Versed and they go away and you're like, am I really I just had that on like a 20-year-old radiology nurse in our hospital. So PVCs go away. Our anesthetics work really well for that, unfortunately. And so this, I think, is another sort of a tool to be able to, help us with that. But it really can help with predicting whether it's something you felt was safe and doable and within, the realm of your expertise, so to speak.
And just to add to that, I'd say, the peri-procedural planning is the big part, right? As you alluded to, Devi, that if the reticence is that, there's uncertainty in how long the procedure will take or the complexity, this can help provide a little bit of guidance. And maybe just to add some clarity to the accuracy, the original evaluation for VMAP was intended to be around focal arrhythmias, primarily around VT and PVCs. And in that setting, in about 200 plus patients, it had a 97% regional accuracy. So, it's getting us into the ballpark. And so what I mean by that is it's going to put us roughly about 1.5 centimeters from, the area of interest. So it's great to see the cases that are right on, but, to get us in the ballpark is also quite helpful, I think, for most of us.
What can you tell me about the clinical evidence with this system that's out there? You just mentioned about the VT study, but how about for the other arrhythmias?
Yeah, so the other arrhythmias constituted a smaller proportion of that particular study. And again, the grade was really, can you be in the region of interest? They also looked at a total of 51 segments, and in fact, demonstrated that for focal arrhythmias, there was a greater than 95% confidence to be either in the segment where the arrhythmia was originating or just adjacent to that segment. So I think for focal arrhythmias, the evidence is strong. For atrial fibrillation, there was an abstract that has been published essentially looking at 75 patients, 50 of which were controls, looking at a PVI plus strategy. In essence, patients who were in the treatment arm underwent a traditional PVI and then had a emphasis on one or more hotspots in the left atrium. And at least in the short-term follow-up, they were able to show nearly double the success as far as freedom from arrhythmia. There's, of course, significant limitations to the way that some of these evaluations were completed. But I think on the whole, there's an early promise to say, hey, let's do more. Let's try to understand more.
Yeah, Debbie, you bring up a good point, though, right? We need clinical evidence for all the things that we do, right? And we want to be able to see prospective work. And the nice thing is we're pushing for those kinds of things. And, we mentioned PFA. So wouldn't it be great if we had a prospective trial in which we used AI-guided PFA ablation for non-PV triggers, rotors, whatever you want to call it? Those kinds of concepts I think are super exciting, but we're really early on in the space. So we have to be cautiously optimistic, but really push to make sure that we have the appropriate clinical evidence that shows that this is better. Because now we're feeling like we can ablate anything with impunity, at least in the atrium these days. And so, I could isolate the veins, the posterior wall, the appendage, the SVC, the CS, the Krista, the CTI, but should I be doing that? And if something could guide me as to where, beyond what I think is best or what my eyes see, I think that is a really, really compelling future.
Atul, I want to just ask you a question. Oh, go ahead. Go ahead.
No, I was just going to say that I think the application in VT is very, very exciting because although I was always drilled to be able to try and localize these things by the 12-lead ECG, we know from the number of algorithms that keep getting published that we're not really all that good at it. And so to be able to immediately get to a region of interest is very, very helpful. And that 80-minute period of time was very compelling, Ben, because, seeing how you were able to quickly triangulate all of that data to a very specific area of interest and not have to take away another 5% of ejection fraction to get there was really, really quite elegant and quite nice. And, I think you're going to get there for AFib. I just saw a case in clinic this morning, 2 prior ablations, posterior wall veins all isolated, other late fractionated areas isolated in left atrium. And now we're thinking of going in for a third procedure. And I would love to be able to use VMAP or something like it to be able to look at, where are the triggers coming from now in sinus rhythm? Is there any activity in the right atrium? Should I be going after the SVC or other things, given that the left atrium has essentially been done? So I think it's an exciting territory.
Well, thank you again, Anish and Ben, for showing us an opportunity with this technology that could potentially give a more personalized approach to taking care of AF and VT. And thank you, Atul, as well, for joining us on the panel. We're running short of time. And so next up, I'm actually going to hand it over to a longtime Rio Coast co-director, Jason Andrade, to take you through the rest of day 2. Stay with us.